Hello dear friends, how are you doing today? I hope you are doing well. Welcome to a new question about dermatology. The skin in the mirror of the body is the biggest organ of the body. Okay, a 72-year-old man is investigated for oral ulceration. A biopsy suggests Pemphigus vulgaris. This is most likely to be caused by antibodies directed against A. Hemodesmosomal BP180, occludin 2, hemodesmosomal BP230, D. Desmoglein, E. Adherence. Okay, this question is asking about the autoantibody against the skin contents in Pemphigus vulgaris. In Pemphigus vulgaris, we have autoantibody against desmoglein 3, and in rare cases we have autoantibody against desmoglein 1. Okay, thus the answer is desmoglein. Okay, explanation. Here we are going to explain more about Pemphigus vulgaris. Pemphigus vulgaris is a rare, serious autoimmune blistering disorder that affects the skin and mucous membranes. It occurs when the immune system produces autoantibodies mainly against desmoglein 3 and sometimes desmoglein 1, which are essential proteins that help skin cells stick together. This leads to loss of cohesion between cells or acantholysis, resulting in painful flaccid blister and erosions. As we said, the painful flaccid blisters are the characteristics of Pemphigus vulgaris blisters. In conclusion, Pemphigus vulgaris is an autoimmune disease caused by antibodies directed against desmoglein 3, which is a cadherin type epithelial cell adhesion molecule. Okay, here we can see the mucosal involvement or mouth involvement in patient with diagnosis of lupus vulgaris. Here we can see the lesions of a Pemphigus vulgaris patient. As we said, the lesions are usually painful, flaccid blisters and erosions. Because of the blisters are superficial, they rupture easily and we cannot see any clear blister on the patient's body. Okay, they are painful, but we cannot see any itch, or the patients don't complain of itching of their lesions. Okay, key features. Mucosal ulceration is common and often the presenting symptom. Oral involvement is seen in 50 to 70% of patients. As we said, one of the first presentation of patients with Pemphigus vulgaris is mucosal ulceration. Okay, skin blistering, flaccid, easily ruptured vesicles and bulla lesions are typically painful but not itchy, as we said. This may develop months after the initial mucosal symptoms. Onset in middle age or older adults. Blisters are fragile and easily ruptured, leading to painful erosions. Size often begins in the mouth before spreading to the skin. Nikolsky sign is positive and skin shears off with gentle pressure. Histology, usually we can see intraepidermal blister with acantholysis. An intraepidermal blister is important in Pemphigus vulgaris. We can see acantholysis also. Diagnosis usually confirmed by skin biopsy and direct immunofluorescence. Diagnosis is usually with clinical presentations, signs and symptoms, but we can confirm it by skin biopsy and direct immunofluorescence. Okay, blister or bulla. If the patient is coming with blister and bulla, if the patient has mucosal involvement, the diagnosis would be Pemphigus vulgaris, because in 70% of patients we have mucosal involvement. But if the patient has no mucosal involvement, then the diagnosis would be Bullous Pemphigoid, because mucosal involvement in Bullous Pemphigoid is very rare. Here we are going to compare some differences between Pemphigus vulgaris and Bullous Pemphigoid. The appearance, we cannot see any clear blister on the body of patients with Pemphigus vulgaris. As we said, their blisters are flaccid and they rupture easily because they are superficial. But in Bullous Pemphigoid, we can see clear blisters on the surface of the patient's body. Okay. Mucous membrane involvement in Pemphigus vulgaris we have in 70% of patients we have, but in Bullous Pemphigoid, mucous membrane involvement is rare. Autoantibodies in Pemphigus vulgaris we have autoantibodies against desmoglein 3, but in Bullous Pemphigoid we have autoantibodies against hemidesmosums, and this is important. Blister locations in Pemphigus vulgaris we have intraepidermal or superficial blisters, but in Bullous Pemphigoid we have subepidermal or deep blisters. And blister quality. The blisters in Pemphigus vulgaris are flaccid and they rupture easily, but in Bullous Pemphigoid the blisters are tense and firm. Nikolsky sign. Nikolsky sign is positive in Pemphigus vulgaris, but in Bullous Pemphigoid, Nikolsky sign is negative. Okay, prognosis in Pemphigus vulgaris unfortunately is poor, but in Bullous Pemphigoid we have a favorable prognosis. Management is usually with first-line systemic corticosteroid, example prednisone, and adjuncts in immunosuppressants like azathioprine, mycophenolate, amphitryl, biologics like rituximab if systemic corticosteroids is not responding well. Sportive care like wound management, infection prevention, and nutritional support. Okay, this was an explanation about Pemphigus vulgaris, the differentiations between Pemphigus vulgaris and Bullous Pemphigoid. Thank you for your attention.